This is Heart Rhythm TV, and I'm Dan Alyesh, reporting from the HRS23 scientific session in New Orleans. Just fresh out of the late-breaking clinical trial session on innovations, and I'm joined today by Dr. Jacob Sroubek of the Cleveland Clinic and Dr. Pasquale Santangeli of the Cleveland Clinic now. And we are here today to discuss their study, the first in-man experience with Impella 5/5.5 as a hemodynamic support device in patients with high-risk patients with ventricular tachycardia. Okay, and 82 patients in a retrospective, propensity-matched study with 41 patients in each arm. First off, congratulations, and can you tell us a little bit about the study you did and what you found?
Sure. So yeah, I wish it was randomized. It was a retrospective 41 patients that we identified that have been, supported with Impella 5.0 and 5.5 at Cleveland Clinic for VT ablations, and these were propensity matched. We looked at both safety outcomes as well as recurrences of VTVF as well as death, LVAD, and transplant. We found that with respect to the long-term survival, free of death, LVAD, or transplant, and with respect to survival free of VTVF, there were no differences. However, there were more complications in the Impella supported group.
Yeah. Well, that's very interesting. A couple points I want to make about what I observed with your patient population. The median EF is 25%. The majority of patients are NYHA class 3 and 4, and the majority of patients presented with STORM. So a really challenging patient population. Tell us a little bit, tell us a little bit about the Impella devices, just so people who can understand 5.5, a little bit about the mechanics.
Yeah. So these are large axial flow devices that are capable of producing up to 5 or 5.5 liters per minute of flow. They're inserted by surgeons through axillary artery approach. What they do is they cut down to the axillary artery and they place actually a graft to the artery, and then it's inserted across the aortic valve. And it provides continuous flow that can be adjusted during the procedure as needed. Usually the implant is done a day or more before, and then we have encouraged rapid weaning, so usually the removal was 1 or 2 days later, although in some patients it was required for a longer period of time.
So, an enhanced ability to map in VT, and we always love when we can map in VT, to really get to the physiology. But my question, I guess, to you, Pasquale, is the complications. Can we elaborate a little bit more about that to understand what that means for the patient when you make the decision to use this device?
Thanks, Daniel, and thank you for featuring us. So I think that's actually the major finding of the study. Really, beyond the fact that we didn't find a benefit in terms of death, LVAD, transplant, and VT recurrence, the major finding is that anything you do in these patients comes with a price, with a cost, essentially. And this was a big device. We thought, okay, maybe going with high flow is going to help us a little bit more for some heart failure, acute decompensation, early mortality, and VT recurrence, because we can map more VT. That's what we thought initially. But in fact, actually, it did backfire quite a bit, because we found up to more than 20% complication rate. Half of them were roughly related to the surgery itself for the Impella placement. We do know that any complication counts, and any complication can impact long-term mortality and short-term mortality. So I think any potential benefit, maybe there was a signal in the noise, was entirely offset by this incredibly high rate of complications. And I think that's actually one of the major findings of our study. Yeah.
Regardless, an important piece of data, an important thing that needed to be done. Okay, and I think, Jacob, you commented a little bit about there may be a niche role, and providers or physicians should look at their cases and still make those decisions themselves.
Yeah, I think that's true, and I can tell you myself, since we have done the first analysis of these data, which is now over a year ago, when I noticed that really we have a tough time predicting who's going to benefit from the Impella and who is not, I've adjusted my practice. And for example, the only one case I've done since, was a patient who has failed prior 3 ablations and had hemodynamically unstable VT, which was not mappable. The imaging did not make any sense. It was not useful in predicting where to ablate. So the patient was out of options. And this particular patient, I did choose to use the Impella for. Yeah. No matter, it was actually not even that high risk in terms of the Pain's D-score, And I do have to say this was done maybe 6 months ago. He's still VT free as a result of me actually knowing where to burn because I was able to map during VT.
Very good point. Now, final question, okay? There's so much now being written about characterizing the substrate in sinus rhythm, right? ILAM, D-cell zones, deep mapping, for understanding the substrate, understanding the likely location of the isthmus. Where, you know, as far as future directions for the Impella in that context, what are your final thoughts on that?
Well, so I'll start with that, saying that whenever you can map in sinus rhythm and keep a patient in sinus and you can define the substrate in sinus rhythm, go for it. So induction of VT, even in the healthier patient populations that are not included in our study, we study really the sickest of the sick. It's always overall, I'm not going to say a bad idea, but it always comes with some form of compromise in terms of hemodynamic stability and also with acute, potential for acute decompensation. There is a group of patients, though, that we cannot do that. And I think another group that I would like to add to what Jacob has said, patients with a high pain score. And again, even in this study, again, the pain score was another predictor of essentially sick patient population because we had high mortality rate in a patient with a pain score greater than 17 on average. Is a group of patients with high pain score and very high burden of unstable VT or incessant VT. Those you just cannot define the substrate in sinus rhythm. And therefore, you are almost compelled to put some form of hemodynamic support device to terminate the unstable VT, and then you can work in sinus rhythm afterwards. But I agree with you, if you can define, if you can work in sinus, go for it.
Well, congratulations on a well-done study. Adding to the literature, we appreciate answering the hard questions, and thank you all for tuning in to Heart Rhythm TV.